My name is Lisa Heikoff. I'm a physician at Kaiser Permanente here in San Diego. I have training in internal medicine, fellowship in geriatrics, and then additional training in hospice and palliative medicine. So I'm boarded in all three subjects. And I am the director of the continuing care services and the home care and hospice and palliative care services at Kaiser here in San Diego. I'm also on the board of the local Alzheimer's Association, and I have taken to also adding my personal connection to this disease, because we all have a personal connection. It's less than 6 degrees of separation, and so when I talk and when I make time in my schedule to talk and connect with people, it's because my very dear brother-in-law, who is my exact age, 60, has been diagnosed with Alzheimer's disease and probably has had it for a couple of years, had to step down from his professorship at a university. It's been a very life-changing event for our entire family. And so when I'm talking, I'm not just talking, in theory. I'm kind of walking the walk along with all of you. So we're going to talk a little bit about partnering with your physician. Of course, whatever health insurance program you work with, whatever type of system you're involved in is going to change, what your relationship and connection is with your physician. So some of this is a little generic, but I think the take-home message is fairly universal. Okay, the couple things I'm going to touch on, and I tend to pack too much into my short piece of time, so we may cut off a little bit early, but I want to just talk about some of the definitions of what used to be called mild cognitive impairment, now called mild neurocognitive disorder, and what used to be called generically dementia, and now is called major neurocognitive disorder. Anyone familiar, who works in the field, familiar with the DSM, Diagnostic and Statistical Manual, how they label different illnesses of the brain and the mind? It was recently revised, and they came up with these 2 new terms. So you might start to see them. It's fairly new, just came out in the spring, so you might start to see some of this in literature that you're reading about dementing illness. Talk a little bit about signs and symptoms, talk about early diagnosis and why it's important, a little bit about the medical treatment, and then assuming that we have some time, I want to really touch a bit on some lifestyle changes, a little bit about advanced directives, and then some things about social and spiritual support and how they affect your course. So just the definitions: mild neurocognitive disorder is the new long-winded title for what used to be called mild cognitive impairment. And that's really the mild memory problems that we all experience as we get older, the difficulty coming up with a name. Who was the author of that book? It had a red cover. It takes the book club, half the night to get that title or author out, but eventually, it's what I call it takes a village to complete a sentence. We all experience that along the way, right? Everyone's laughing in recognition because we all experience that, and we all think, uh-oh, is that dementia? Am I developing Alzheimer's disease or some other form of dementia? Major neurocognitive disorder is the term we now give for dementia, which is a global term for all of the dementing illnesses, including Alzheimer's disease, that is much more than simple word finding or mild recent memory deficits. And it speaks to a more global dysfunction of the brain, where there are memory problems, language dysfunction, visual spatial orientation issues that lead to the kind of getting lost or being uncertain in unfamiliar territory, and what we call executive function, which is the ability to take in a bunch of information, synthesize it, and make a plan for what to do next. The most common form of dementia is, of course, Alzheimer's disease. So there's a lot that we don't know about things. Is the mild neurocognitive impairment indeed a prelude to dementia or to Alzheimer's disease? That's still in question, and there's debate about it in the research community. Is it really the earliest tip of the iceberg for what may decades later become dementia? Or is it part of normal aging, whatever that is in the brain? There may be it's mostly naming and word finding problems, occasionally a little bit of trouble with concentration or retaining new information, a little more difficulty with familiar tasks, but not clearly progressive, and people may have these symptoms, for many decades without progressing on to frank dementia in all those other spheres of brain function. Early stage dementia, which can sort of tag on to the mild neurocognitive impairment, things that are a little worse and a little more of the spheres of the brain function, including decreased recall, trouble with calculations, executive function problems like not being able to plan social events or difficulty at work with more complex organizational things. And people may experience some personality change with that, in part because of the insecurity of suddenly having difficulty. And so the family member or partners or friends may notice a change in personality with some withdrawal, and somebody who maybe previously was very garrulous and sociable suddenly kind of withdrawing a bit out of fear of getting stuck and not knowing how to proceed forward in a conversation. And likewise, more difficulty finding one's way in a new environment. So there is another session later about Alzheimer's disease research and where things are going. I'm just going to mention a couple of things. So dementia, or major neurocognitive disorder, describes several different diseases which can be clinically very similar. Alzheimer's disease is the most common cause. We know that there are certain plaques and tangles that people see in the microscope when looking at the brains of people who died of Alzheimer's disease, and those have been identified decades ago. Vascular dementia is the result of multiple strokes, and this could be big major strokes where somebody had a clear event that's identified as a stroke, or it may also be a collection of small injuries to the brain in people who have high blood pressure, diabetes, smoking, high cholesterol, all the things that are precursors to stroke disease. Sometimes you don't see a frank big stroke, but kind of a collection of small areas of damage. And what we're finding out is that those vascular risk factors and that vascular aspect of dementia is probably a cofactor with Alzheimer's disease. And it's sort of a good news, bad news. It means that those same things that your doctor's always telling you about, lose weight and healthy diet and reduce, animal fat in your diet and exercise more, those are probably just as pertinent for staving off or delaying dementia as they are for delaying or staving off cardiovascular disease. So the good news is one size fits all in terms of prevention. All of those things are things we should be incorporating. The bad news is there isn't a magic tip to preventing Alzheimer's disease, like take more vitamin D or take more coconut oil or anything like that. Some other forms of dementia: Lewy body dementia is associated with Parkinson's disease. Frontotemporal dementia is another variant, and they're all associated with slightly different biochemistry that researchers have identified, and that different biochemistry leads researchers to have different tools to look at to see, is it something that's in the production of this protein that leads to this form of dementia? And I think you're going to hear more about that later, so I'm not going to dwell on the science of it at the moment. One other comment that I really want to emphasize from the science, however, is that one of the things that we have known for a long time is that there's a neurotransmitter, a brain signaling chemical in our brains called acetylcholine. Acetylcholine, and we've known that there's a decrease in the level of acetylcholine in the brains of people with Alzheimer's disease. And you can actually track the decrease in acetylcholine along with some of the clinical onset and symptoms of Alzheimer's disease. This is important for two reasons. One is that it has, again, led researchers to look at how acetylcholine is made in the brain, how it's eliminated from the brain. Can you increase the level of acetylcholine? All of the medications that we currently have, Aricept and Exelon, galantamine, the way those medicines all work is by increasing acetylcholine in the brain. So that's how they work to help reduce some of the symptoms of dementia, of Alzheimer's dementia. However, the main lesson for this for most of us is that there are a lot of drugs out there that are commonly taken and a lot of over-the-counter medicines that have anticholinergic side effects. I mean, if you're familiar with this, fine. If you're not, write it down. Anticholinergic. Because whenever you're prescribed, if you have dementia or memory problems, whenever you're prescribed a new medication, you want to ask your doctor or pharmacist, does this have anticholinergic side effects? Because if it does, it's going to reduce the amount of that neurotransmitter, acetylcholine, in the brain and could affect your alertness and your memory. It doesn't make the dementia worse per se, but it may temporarily make your brain function worse. And so the most common over-the-counter drugs that have the anticholinergic side effects are things like Benadryl, the older antihistamines. Now the newer antihistamines like Zyrtec, those do not have this effect so much. Every over-the-counter medication that says PM on it, Tylenol PM, Motrin PM, those elixirs of flu and whatever medicines in a bottle that have alcohol and a lot of stuff in them to make you sleep, most of them have Benadryl in them. That's what makes you sleepy. And it's fine if you're 40 and have absolutely no cognitive problems, but if you're over 65 and if you're suffering from memory problems, the anticholinergic effect of that Benadryl may have serious consequences for you. So it's a really important thing to know and to rely on your physician and maybe even more helpfully, your pharmacist to identify those medicines that you're taking that may have anticholinergic effects. Now, sometimes you can't help it. Sometimes you just absolutely need a certain medicine. It does have anticholinergic side effects, but at least if you know about it, you can be monitoring to see, is it affecting me or not? And if it's affecting you in a negative way, work with your doctor to find an alternative. A lot of people ask about the genetic predisposition for Alzheimer's disease. And what we know is that most of the cases of Alzheimer's disease that we see across the country and across the world are what we call sporadic. There isn't a strong family history, although it's a common enough disease that almost everybody knows someone in the family who may have had it along the way. There are some very small groups of families that have a strong genetic variant of Alzheimer's disease, but those are very rare. Since the human genome has been translated and identified and people are starting to do more genetic work, there probably will be some genetic predispositions to the development of Alzheimer's disease and maybe an ability to separate out the genetic predisposition to other types of dementia along the way. But right now, from a clinical standpoint, a day-to-day, talk to your doctor standpoint, the genetics really don't come into play. There's a gene called ApoE, which is related to lipid metabolism. We do know that people who have, we get 2 copies of every gene, one from our mother and one from our father. And there are several variants of this ApoE gene. We know that people that have 2 copies of ApoE4, so if you're 4-4, have an increased lifetime risk of developing Alzheimer's disease. Whereas if you have E2, E3, E1, less so. However, there are people that are E4 and don't develop Alzheimer's disease. And there are people who have no E4 and do develop Alzheimer's disease. So it's clearly a factor that's modifiable by some other genetic factors, and this has been known for a long time and has not yet led to anything helpful clinically. So it's kind of an interesting fact that tells us there's probably a genetic linkage in there somewhere, but we haven't figured it out yet. So what's the partnering with your physician and the advantage to early diagnosis? What is that about? And I'll tell you, it's controversial. I was actually just reading in a journal article over the weekend in one of the geriatrics journals that actually challenged the idea that early diagnosis is helpful. That maybe we all would rather just cruise along thinking we have mild cognitive impairment that's not going to go anywhere, and maybe that's a better way to live. Maybe denial is a good thing and, the better way to go. It may be for some people, and I think people kind of make that choice consciously or unconsciously by either raising it with their physicians when they notice cognitive problems, memory problems, or by keeping quiet about it. So I think some of us are making our own decision about that. I personally stand on the side of saying early diagnosis is important. And I hope I can explain to you why I think that is. I think that the earlier you diagnose any chronic illness, the more control you have over managing the risk factors and dealing with the psychological and social and financial implications of knowing that you have this illness, pending, that's going to evolve in your life. It may change how you manage your finances. It may change when you decide to retire. It may change things about your family structure and where your kids live relative to you. It may have broad implications that may really matter. So I personally think it matters, but it does take courage. It takes courage to go to your doctor and say, you know what, I've been experiencing some memory lapses, or I got in the car and got lost on my way home from the supermarket, and that just never happens. It takes some courage to bring that to light and to be willing to hear what that might mean. So I think we all kind of make that decision, as I say, consciously or unconsciously on our own. The other really important reason, I think, to seek early diagnosis is that if a diagnosis of a dementing process is made, there are a lot of resources out there to help you. There are financial resources, emotional resources, legal resources, and you don't get to use those if you don't know what's going on. So that's my case. So what to expect from the diagnostic process? It's my belief that most primary care physicians who deal with older populations are perfectly capable of making this diagnosis, doing the appropriate tests for the vast majority of us. And it's only in the unusual case, a very young person with a dementing process, or somebody in whom the symptoms are very subtle and hard to sort out, or there are seizures or something really unusual about a case where you must see a neurologist. But just as you would ask if a physician has done a lot of appendectomies before you let them take your appendix out, I think it's reasonable and fair to ask a physician, are you comfortable making this diagnosis? Is this something you do often? And if they say, gee, it's not really something I know a lot about, then that's the time to ask for a referral to either a geriatrician or to a neurologist. I would say most internists do care for older individuals and are competent in handling this diagnosis. You can expect to have a battery of blood work done, a lot of blood tests. There's no specific blood test for Alzheimer's disease. You're really looking for things that can affect memory and thinking other than Alzheimer's disease to make sure you're not missing some other more easily remediable problem. The number of times that really gives you a clear alternative is small, but certainly worth pursuing. And those are going to be things like thyroid dysfunction, a very low level of vitamin B12, which can affect brain function, calcium levels that are too high or too low. There's a variety of things. It's a pretty standard package of lab work. If you're at risk, HIV testing is also an important test to have done. And then you'll have some form of a brain scan. And you may have heard, if you've been reading about Alzheimer's or hearing about Alzheimer's on the news, there is a scan for that amyloid protein that I referred to, this red staining protein that we see in the brains of people with Alzheimer's disease. It's not yet approved by Medicare or anybody for sort of standard diagnosis out in the community. And the reason for that is that some amyloid is normal. A lot of amyloid isn't abnormal. And where is the cutoff exactly for normal and abnormal? We don't really know that everybody who has a little amyloid will definitely progress to a lot of amyloid. So the concern is that by doing this test and having everybody find out how much amyloid they have and then going to their doctor and saying, do something, and there's not a lot of information. Those commercials, those direct to consumer commercials on TV. Ask your doctor. Those. I'm the doctor, and I'm sitting on the couch, and I'm looking at that. I'm going like, this drug came out yesterday. Like, if somebody asks me about this, I'm not going to have a lot to say about it. I'm going to be on the internet looking it up just like you are. So tests and drugs that have not been around for a long time that we don't really know what to do with aren't that helpful. So an amyloid scan is probably only something that you're going to have if you're participating in Alzheimer's research, which is a good thing to do, or in very unusual situations. So the brain scans that we do, either a regular CT scan or an MRI scan of the brain, those scans are looking for that vascular disease, the large or small strokes, accumulation of injury from hypertension and hyperlipidemia and smoking and things that affect our blood vessels, looking for brain tumors, heaven forbid, which could masquerade initially as a dementia, looking for signs of brain trauma. We all heard about the football players with dementia after brain trauma. So repeated serious brain trauma can predispose to dementia. And so we're really looking for the things other than Alzheimer's disease that can be physically seen on a brain scan when we do those scans. I'm running out of time. The doctor should definitely take a complete medical history, and most importantly, you need to bring all the medications that you're taking, including supplements and over-the-counter medicines when you go to the physician, not only for your initial evaluation, but every visit. That's really, if there's one take-home message, bring them all, bring the shopping bag if that's what it takes, all the over-the-counter medicines, supplements, etc. And if your doctor seems unsure about how to advise you, again, your pharmacist is a really good and I think underutilized resource for information about medications. We talked about this. In addition to the brain scan and the blood tests and a general history and physical examination, your doctor will use some form of testing your memory, and there are several different tests out there. And in most cases, these kinds of office-based tests are sufficient. People don't need to go through a huge battery of what's called neuropsychological testing. Again, unless there's something unusual about the situation. The symptoms are unusual, the person's very young, there are seizures or other things that don't typically occur early in a dementia process. You think there may be something else going on. And if English is not your primary language, or the primary language of the loved one you're looking after, please ask that these tests be administered in the primary language, because there is can be a significant difference. So the medications that we use address this acetylcholine deficit that occurs in the brain with Alzheimer's disease. And so Aricept or donazepam, Exelon, Razidine, those three medicines all work by slightly increasing the level of acetylcholine in the brain. And that's why people get a good response early on when they take those medicines. And that's why as the disease process continues and the acetylcholine level fades, the medicines stop being as effective. And so we generally think that people do well for a year or two on those medications. Once you get way past that, 5 years or more, they're probably not helping and they do have side effects. So my other take-home message is don't be on those medicines forever. Check the side effects, which decreased appetite and weight loss can occur, especially late in dementia for people on those medicines. And sometimes people do much better when you take them off. They're not miracle drugs. They have a specific effect for a limited period of time. Namenda is works on another neurotransmitter system. Again, there's some debate about whether to use those together or separately, but your doctor will sort of make a decision based on how you're tolerating them. And again, in very late stage dementia, these medicines tend not to be of much help. I advocate that anybody who's interested contact the Alzheimer's Disease Research Center at UCSD to see if you're eligible to participate in a study. They're looking for well people also to participate in studies, and can be a very gratifying thing to do. I'm down to my last few minutes here. I do want to just mention that while people get very excited about magical cures and, one drug wonders, there's no one drug wonder for dementia or Alzheimer's disease in terms of supplements and those kinds of things. The most important issues are to face the conditions that cause vascular disease, your weight, your blood pressure, diabetes, smoking, all the regular things that we know improve our general health are also the things that reduce that instigation of dementia that vascular disease contributes to Alzheimer's disease. We're probably getting out of time here. I did start a little bit late. Last couple of comments. If you're experiencing anxiety or depression, those are concomitants of any chronic illness, every chronic medical illness. And again, you do better, in my opinion, if you share that information with your physician and get help and treatment for those conditions as well as for the dementia. And I think I'm probably going to need to stop there. Medications for behavior is sort of another issue that will come up, highly individualized. These are not these antipsychotic medications that we sometimes use for very agitated behavior. These are not targeted. These are not like insulin for a diabetic. We're kind of using them for their kind of global sedative effect. If these behaviors can be managed by environmental change and communication, compassionate communication and redirection, it's far better than using medications. That having been said, there are situations where medications become necessary, and that's a highly individualized situation. All right, so I'm going to stop there, and I don't know if we have time for a few questions or if we just need to move on.
I think best is people can move on, but if you want to come up front and ask some questions of the doctor.
Or maybe in the back. Should I do it in the back so I'm not a distraction?
Okay.
I'm going to go back just outside the door. So, and I have a few minutes, but if you have a specific question. Thank you very much.